All right, perfect. Good afternoon or evening, wherever you're joining us from. This is Jared J. Wallen, MD. I am filling in as a guest host for Jeff Cantor and Charles Froman. This is the next episode of Your Freedom Hub, presenting the free market cash patient, sponsored by your.mp.com and Freedom Hub, Your Freedom Hub, the disruptors intersection, uniting freedom activists and entrepreneurial disruptors for a better world. Obviously, there's a significant problem in medicine these days with many middlemen, including insurance companies, corporate hospitals, and others, and the government and politicians getting in the way in between, where patients and physicians need or healers meet. And obviously, this is the focus of this podcast. Thanks for joining us tonight from wherever you are. Again, obviously, part of this has been specifically highlighted by last year and the COVID crisis, with all the different changes in regulations and such, including wearing multiple masks and all these other things that seem to change by the day. And obviously, we were all just kind of along for the ride in the government's situation there. So ultimately, again, Your Freedom Hub, you can connect. There is a 4 p.m. podcast. The Freedom Hub Working Group every Wednesday at 4 p.m. You can find that on BitChute, on Brighteon, on YouTube, and also on Rumble. Also, this 7 p.m. podcast is also every Wednesday. You can find it all on similar channels as well. And we'll show you how to get there in just 1 second. Again, obviously, sponsored by patientempowerment.mpb.health. And again, those are our links. We'll certainly show those again at the end and walk through that. So just getting to the website, so you can see this is the yourmpb.com or yourmp.com. And basically this is the homepage. If you scroll down, actually you can see here where we have our guest speaker tonight, Lauren DeLuca. We'll talk about more in a minute here about Lauren, but ultimately you can see here, this is her section here, and ultimately it will highlight all through the previous guests and some upcoming guests as well, including last week's guest, Sean Needham, an integrated pharmacy health reform expert. Whereas again, you can find all the links to both the Freedom Hub Working Group as well as the Cash Patient series here on the homepage there. So from that standpoint, again, thank you so much, Lauren, for joining us. Ultimately, Lauren has a significant history and a degree in finance, spent about a decade or so in the insurance industry, and then unfortunately was diagnosed with a rare, although significant disease, and ultimately became one of these pain patients that the government has kind of limited the prescriptions significantly for, and made it very difficult for folks to get necessary medications to help them live and have a good quality of life. And so without further ado, Lauren, I'm going to turn this over to you. Thanks so much for joining us, and thank you.
Thank you. Thank you for having me. I appreciate being here. My name is Lauren DeLuca. I'm the founding president of Chronic Illness Advocacy and Awareness Group. I'm here today to discuss our review and our thoughts on what is called the National Pain Strategy. And this is something that a lot of people are not as familiar with as other things, such as the DEA impact on patient access to medicine, as well as the CDC guidelines that limited opioid prescribing. And I think that it is very noteworthy in our organization's work. We focus a lot on how we got here as a community, and we have found that the root cause of a lot of the changes that we are seeing in today's medicine in the healthcare field and the way that pain itself is being treated really goes back to the directive of the National Pain Strategy and how that is influencing our access to care. It's influencing the CDC guidelines, and other guidelines were being created, as well as the DEA's own directive on how to handle, dealing with raiding doctors' offices and things of that nature. So I wanted to just today, I'm going to go ahead and share the screen. We put together a nice presentation that's just going to go over the background of the National Pain Strategy, so we can go ahead and kind of just see how we got here as a community and take you guys through that. So as you see here, it's just National Pain Strategy. Is it working? And today here we just have a slide for my contact information. I have no financial disclosures or conflicts of interest to report, and we are funded by public donations. We do not have any large investors, grants, or any of that kind at this time. So we are solely funded by personal donations at this time. We have our Twitter and our email contact there as well. So for today, we wanted to just have some objectives about how did we get here, to discuss the National Pain Strategy directives. What has its impact been since it's been implemented in these past few years? And how do we move forward from here as a community based on the information that we're going to be presenting here today? So I think the best way to move forward is to really understand the historical steps that had to take place before the National Pain Strategy was issued, to understand how we changed as a nation so dramatically in the past 10 years with healthcare. And actually, on our step one here, in the year 2000, the Pain Relief Promotion Act, HR 756, had been passed. And what that did is it promoted pain research to be conducted on the treatment of pain. And it did promote, it was supposed to promote the use of palliative care without assisted suicide being as an option, which, all sounds fair and good. We want research. These are all positive things, especially in the nature of that palliative care was supposed to be promoted. Unfortunately, we haven't seen a lot of that actual palliative care get promoted. But what this did do is it laid the groundwork to open up a lot of what you would want to say the groundwork, literally, to get everything off the ground, to start the studies and the reports that were going to take place in the year 2010 to 2020. So between 2010 and 2000 and 2010, a lot of preparatory work had taken place. And then in 2010, the Affordable Care Act actually was, as we all know, that passed and really shifted the shape of medicine as we know it. In particular, under Section 4305, they had created the National Prevention, Health Promotion, and Public Health Council within the Department of Health. What this is, it's a 15-person council, and it is appointed, the individual who's the secretary of the 15 major agencies at the federal government level are the individuals who sit on this committee. So you have the Secretary of Transportation, the Secretary of Defense, the Secretary of Education, the Secretary of Health. You have all of these different secretary heads sitting on this committee, and they were put together to develop a number of strategies to help deal with healthcare in the United States. And the ACA had also dictated what was going to begin and was called the Decade of Pain Research. Within that document as well, the ACA created the agency now known as PCORI, which is the Patient-Centered Outcome Research Institute, to be one of the flow-through agencies for these studies to take place on the best treatment of pain. And this was being promoted under the idea that, if people consume less healthcare services, people have less pain, that we will not need to give out opioids. And this is a part of the research that we are seeing take place today. So back in 2010, the Health Promotion Prevention Committee had created, and the 467 objectives were promoted through what is called the Healthy People Campaign. Now, the Healthy People Campaign is designed to run every 10 years. So we have the Healthy People Campaign 2010, 2020, and 2030, and each one has a different focus area. So in 2010, the Healthy People campaign was also taken place. So in 2010, we have all these these interrelated actions, taking place. And within the Healthy People campaign, they developed the 467 objectives that were to serve as a framework for the first decade of research, which is your, 2010 to 2020 term, and that is called the Decade of Pain Research. And what they wanted to do during this decade, what did they want to learn about pain that they didn't ever get to know before, because patients were dropping out of studies previously, because when they were trying to contrive a lot of studies in the past, people would sign up for them, and if they were in the control group or and they weren't receiving any sort of pain relief, or the modality being tested was inefficient, the patients would drop out. And that was being pitched to the federal government by a number of pain organizations and other entities, that because of patient dropout, they were unable to conduct studies to find out more about the biological nature of pain, the psychological and the environmental factors. And that was really pitched to the federal government to start getting a lot of this research underway. Under the 2010, in 2010, the Affordable Care Act also dictated the formation of what is known as the Interagency Pain Research Coordinating Committee. They are the agency that's basically all the research that's happening at every other agency, AHRQ, CDC, FDA, CMS, you name it. If the other agencies that are doing research, their work flows through to the Interagency Pain Research Coordinating Committee, where they basically go through it and make the strategic decisions about what should be happening with the data that's being received. They're kind of just they're the main hub where all the data flows into. And all of these actions took place in 2010 simultaneously to create the new structure for the healthcare system. And subsequently, when all of these actions had taken place, there was, the Institute of Medicine, who was asked to develop a paper by Health and Human Services, which ended up being called "Relieving Pain in America: A Blueprint for Transforming Prevention, Care, Education, and Research." And what this was, it was a document stating basically a big ask document of what in the world, in a perfect world would you get for research if you could. And they wrote out a number, and when I say they, it's a number, the work group that was involved in this and the other agencies and federal committees that were involved in structuring this came together and wrote out what they thought would be a great way to solve pain in America. But it is all theory based on research and systematic studies that they wanted to take place that had not taken place yet. So this document was then presented and along with a number of other strategies at Senate in 2012. There was a Senate meeting, Pain in America, exploring change challenges to relief. And it was pitched at this Senate meeting that we needed to address pain in a much different way in the United States as a way to address the opioid crisis, as the narrative was being set at that time that because of medical prescribing was really being scapegoated as the reason for drug abuse, when despite the fact that even within a lot of these guidance documents, the committees themselves admit that they don't have research, they do have research that opioids are effective for up to 12 months. There were transcripts that discussed in great detail that they knew that the patients were doing quite well on opioids and were quite unwilling to come off of them in order to try, a non-pharmacological attempt at managing their pain instead. So they needed to construct a new way to manage pain in America, and a public health campaign and a communications campaign that would run simultaneously that would change the public perception of pain to align with what was outlined in the IMO Institute of Medicine report, Relieving Pain in America. And from this action, we have the 2013 Health in All Policies approach was born. And that Health in All Policy approach is that all of these secretary heads under the National Health Prevention Committee that was created under the ACA, it is exactly what it sounds like, health in all policies. So the education, the Secretary of the Education would figure out how can we integrate health into schools through education programs, through different types of healthy eating programs, things like that, as well as just substance abuse programs, to try to fight addiction and stop people from getting sick and developing painful conditions before they do it and before they get hurt, and that this was going to go into all the systems throughout the United States, including transportation, the Department of Defense, and Health and Human Services, all the major committees within agencies within the government have their duties under this strategy to make sure that health is a top priority in their area of expertise. And all of this flows back up through in a massive strategy that has been implemented down at every agency level in a very meticulous and strategic manner. As you can see here on this next screen, there was a number of actions that had to take place just to bring the national pain strategy to the table. In 2014, there was a very powerful meeting, the Pathways to Prevention meeting, where they discussed how can they develop a world and develop a way to implement change into the healthcare system and into society that stops people from using drugs, but also stops people from developing pain and disease before it happens. And that's what a lot of this is about, developing patterns on individuals. And we will go into that a little bit, so I don't want to get off track. So in 2016, the National Pain Strategy was finally published. It was published within a few days, less than a week, I believe. I do not have the exact date, so I apologize. But approximately a week, they were issued within the CDC guidelines. These were complementary strategies that were launched at the same time. The idea is that we have been able to surmise through our research is the National Pain Strategy is asking for population health and a lot of studies to being able to take place. And in order for these studies to take place with the parameters they were looking for, they needed a large, or they, as in the stakeholders, had to have a lot of the patients taken off of opioids. And we'll go into more of that on the next slide. Here, after that, we have seen some subsequent actions that have come out since the National Pain Strategy. They're all interrelated to this, the government's program and action across all agencies to manage the opioid crisis and to try to combat it. But unfortunately, it's been heavily conflated into managing the opioid crisis by managing access to opioids. And we haven't seen much, if any, actual advocacy, money, and work going into the area to prevent substance use treatment. And for example, in that area, under the CARE Act had been issued in 2016, and subsequently we saw the HEAL initiative come together in 2018, and the HHS Pain Management Task Force report, which was issued in 2019, which those task force recommendations were all to implement untested modalities into the general public to be tested and then implemented as best practices. Unfortunately, this has already moved to the point into the Appropriations Committee, and there is being money funded to the House, the Pain Management Task Force recommendations. So before we get into that, so let's just get to the point of what was the National Pain Strategy's point. What was why is this the pivotal issue at hand instead of the opioid guidelines, instead of the DEA, where all of these are major, major issues. And in all of our research, we found it actually all stems back to the creation of this National Pain Strategy, which, as you can see, previously presented, is a very, very complex move, and it is not one singular document. Even what we had shown you is just really a screenshot of many other documents that we've reviewed as well. And under the National Pain Strategy directives, they wanted to change the society's perception of pain, which they do through marketing campaigns, TV, media, social media. We have program DEA 360, where agents are on the internet. How did they promote it? I think they said influencing public conversation. And to me, that's very violating of the public's freedom of speech to have unknown DEA agents online tipping conversations away from what is, I guess, deemed inappropriate. That's a very big concern in our organization, as well as the right violations that are taking place to implement this national pain strategy. And under the national pain strategy, the country took a shift from a biomedical approach to pain to a biopsychosocial approach to pain. And this basically meant that we're not going to treat pain based fully on your physical needs anymore. And when under the National Pain Strategy and how it's been moving forward and all of the related programs and things that we've seen born out of it, is that it's the psychological approach is taking a first and foremost approach, with the biological needs kind of in the back. And we're seeing a lot of people get injured as a result of that because they're not being heard. It's actually it's really promoted a situation where patients are being gaslit. They're being abused when they try to access their care in a manner that was much bigger and much more amplified before this program moved forward. Patients have always had these issues, but they took this program had taken a small problem, that it was supposed to help rectify, and it actually made it a lot more convoluted and a lot more difficult for the patient to deal with. So the biomedical approach is really not the focus on how people get treated anymore, because this has moved forward. And they promote within this strategy self-management above access to medical treatments. So they want non-pharmacological treatments, your acupuncture, your physical therapy, cognitive behavioral health. There's a very large push that pain is actually rooted in childhood trauma, and that it is not actually driven from biomedical factors. And what's very concerning is the intentional ignorance to ignore the biomedical end of what is happening to patients. So it's really tipped this in a dangerous direction because there hasn't been any proper oversight. And unfortunately, when there's a lot of money involved with anything, it's attracted a lot of nefarious interests that are not putting out the proper data and have been engaging in cherry-picked studies in order to skew the data to look the way that to align with the goals of the strategies that have been laid out. And their goals, when they put this together, was to actually reduce healthcare costs by promoting that individuals with chronic illness and disease do not seek medical care and pharmacological treatments as much as they have, and that they learn to self-manage their diseases and their pain at home without medication. And while they are doing this, and this is where it becomes problematic, and as the title of this webinar, Pain Patients Forced into Experiments, that is where things became really violating on the personal autonomy level. In 2017, the FDA had issued a waiver of informed consent for human clinical trials under two conditions. If it was an emergency, which the opioid crisis has been dubbed an emergency, or if it is deemed minimal risk. And a number of these studies that are taking place are applying and taking place under one of these waivers. And so the patients that are being involved in these studies are not being notified that they're being involved in a study. And some of the examples of these studies would be patients going into a hospital to get shoulder surgery, and their doctor is now only going to permit them the 3 days worth of medicine because that's now been promoted as evidence-based. But the evidence is actually lacking. Even though the word evidence-based has been slapped all over it, there is no evidence to state that that is best practices. That is what is being promoted as best practices before it's actually been studied. It's being put into the medical community before the study has been taking place to engage what is called a pragmatic clinical trial, which is a real life, real-time clinical trial taking place within society. So, and the reason that this was pitched was the fact that that patients would drop out of pain studies because the fact that they weren't getting treated and they would drop out. Well, this actually eliminates that ability. They can't drop out because now this is just your medical care, and you're going to get 3 days worth of medication after a certain surgery. And how this works is through hundreds of clinical trials that are running through NIH and PCORI and other federal agencies, where these individual trials are being ran in the private sector, but they're getting the waivers, they're violating patient consent, they're not letting the patient know that they're in a trial, and the patient doesn't have the option to drop out because, as we stated, they don't even know they're in the trial. And if they do know they're in the trial, there is no option for a patient or person with a painful disease right now to say, I reject your care because I'm going to go and get care somewhere else. And this is well understood and was well designed by the various committees and task force and advisory committees that came together to construct the law changes and basically set the parameters up for this to take place through the private medical system. And how the data is being used and how the surgery moves into a trial is that the data is actually then being taken off the EMR to be studied. Now, what makes this different from a normal epidemiology approach to take the data off the EMR, study it, randomize, we found that the data is not always being randomized. There has been cases where patients are being looked for based on the patient attributes, say a study on fibromyalgia. We want to seek out the fibromyalgia patients, and these patients are not necessarily put in a position where they're allowed to reject what is happening to them. So they are suddenly going through a forced taper. And then on the back end, there is a researcher studying this patient's outcome about what happens to them through that forced taper. And at no point does this patient have the ability to drop out. And at no point are they even aware that this is actually being a clinical trial and is untested. It is not tested to force taper people off medication. It is not tested to put people on 3 days worth of medication. And all of these other modalities, the non-opioid therapies, and in particular, the non-pharmacological therapies, which is our multimodal treatments, which is the CBT, the meditation, acupuncture, yoga, things in that nature, have heavily not been studied in this type of manner. So instead of allowing people to sign up for a clinical trial, participate, see if these modalities work out properly, what they've done is the healthcare system has been reconstructed that patients are not being permitted access to the opioid right off the bat as a prevention mechanism. But instead, they're being diverted into these other mechanisms to try them instead. And in the process, this has not been studied and proven behind the scenes, and it is not FDA approved as a treatment for any of these people to actually go through. And on the back end, the electronic medical record is being studied to watch what happens to each of these patients. Do they get sicker? Do they get better? And this is where it becomes a live human clinical trial, and people are getting hurt. This is not minimal risk. This is not normal epidemiology, because they're changing the front end of what happens to a patient, watching it on the back end and tweaking it real time with the subjects, where the subjects don't even know they're involved. So it's become a really, really dangerous situation for patients, for doctors who may not even realize that this is taking place. They're just following orders from admin, and they could have a big study that's being funded that they're not even being told about. And we have had discussions with members of Congress and members of Senate about this in the past several years. This has all been verified. It's not theory. It's not conjecture. We're not reading into anything. These are very, very valid concerns. And unfortunately, because a lot of this has taken place right under the nose of the public, but without anybody showing and bringing it up to to be discussed, it's made its way through the system very, very far without being challenged. And on that note, here we just have mentioned the 6 areas that the National Pain Strategy focuses on, which is your population health, prevention and care, disparities, service delivery and payment, professional education and training, and public education and communication. And these are the 6 sections that were laid out that the National Pain Strategy was supposed to address and or will be changing moving forward, like the professional education, the and the public education and things of that nature are new, really more marketing campaigns than anything else. And so the impact of all of this, I'm sure, as everybody here knows, has been pretty bad. We have had, unfortunately, there is a lack of data availability. And that is one of the issues that our organization is working on, is that the proper studies are not taking place to look at the impact that these policies have had, that the use of pragmatic trials are having on the ability to access care. Instead, all of the studies that are moving forward are really being funded to align with the goals of the National Pain Strategy. I remember I was just at a National Academy of Medicine event where they were talking to, I believe, 400 researchers. And they had discussed the fact that they wanted everyone there to find and construct research that supported the idea to taper long-term opioid therapy patients. So that's not a study. That's an agenda-based call to go create a study to support an outcome that you've already determined. And that's what's been happening with these studies, is they're not studies, a lot of these. They're agenda dressed up as a study and cherry-picked to something that they're just not even anymore reconstructing. They don't represent the proper public that they should be doing anymore. And it's become very, very problematic. And it's resulting in what we've been able to ascertain anecdotally is extreme increase in patient suffering. We have seen increases in suicide. The overdoses have not been impacted by this strategy. They're not going down. People with addiction are not getting the treatment they need because all the money is being dumped into this pain strategy instead of putting money into building rehabilitation facilities, even inpatient, outpatient facilities for people with addiction, focusing on getting people with addiction into mental health treatment centers to help them instead of trying to force rehabilitate people with painful diseases to cognitively manage their disease and no longer, require medicine. We've taken a very backwards approach, and we've seen an exasperation of the areas that this strategy was supposed to fix, which is suicides, overdose, disability, and there's been a big gap of knowledge that we're hoping in the next few years we can advocate and get these studies moving in the right direction. And going on to some other impact areas, we have the opioid prescribing has decreased, but overdoses continue to increase. We've lost our patient consent and autonomy. The artificial intelligence is beginning to replace the physician decision-making on what patients should go to get for treatment. And there's just been an increased stigma and a lot of patient abandonment, refusal to get care, inability to get care as a result of this program. So finally, I just wanted to briefly touch base on how we feel that we as a community and as a nation can move forward with what we're being handed. This is a very, very large strategy. I do not kid myself into believing that it is something that we can roll back and get rid of. But working within where this is headed, what we would like to be able to see is a lot of oversight and a lot of changes to the current and existing network as to how this is moving forward, and to push and to point out the problems that are taking place within it. So we did develop an 8-point strategy at CIAG, which just is really the 8 areas of interest that we think there needs to be change and to be addressed, to start addressing the problems that this National Pain Strategy and all of its related programs and initiatives have really brought into healthcare that they were meant to resolve and had only exacerbated. And we firmly believe the most important thing is oversight of what is taking place and investigations into how some corporate interests have seemed to take a very large portion of control of this issue, with some things bordering what appears to be market rigging more than anything else. And we think that a proper investigation at Congress really needs to take place to ascertain if market rigging has taken place, and if so, hold those accountable for who has conducted in it. We think that there needs to be changes with the education campaigns where we can tweak what's being taught in a more balanced manner, to change the communications, prevention, the disparities. There's financial and opportunity costs because they're not getting the outcomes. The federal government is not getting the outcomes that they seek. And we believe that data and privacy security must have a seat at the table in the development of all of these strategies, because this is a patient rights issue as well as a privacy issue. So we think that there needs to be some new representation at these tables. And finally, it's very important to acknowledge the fact that access to opioids is a harm reduction measure. There is a lot of studies and a lot of evidence that not giving access to opioids has caused increase in suicides, increased use of street drugs or other substances, increased drinking, and things of that nature, because people have not had properly medicated access to opioid medications for their illnesses and diseases. So, as much as we're working as a country towards harm reduction, this step towards regulation where opioids are basically being taken off the table is really, it's increasing the harms rather than reducing them. And we want to point out as an organization and continue to work to the point that palliative care and access to opioids is an absolute necessity in moving forward in the healthcare system, and that it is itself a harm reduction measure and must be implemented in all strategies moving forward. And that's kind of a brief summary. We could get all into those 8 areas in a whole nother webinar or 3, because we have more than enough we could say about that. But I just kind of wanted to take a wrap at that, and thank you guys. I know I've taken a bit longer to do this than I anticipated, so thank you very much for the time, and turn it back to you. Any questions?
Great, thanks so much, Lauren. I will start off. If you'll give me the screen back, I want to pull up your website, and I'd like the first question to be centered around how your experience has basically influenced you to found the Chronic Illness Advocacy and Awareness Group, and kind of bring this, kind of into more of the public sphere. And so, and also, you also have a podcast, right? The World of Pain.
Yes.
And so, as I kind of scroll through your website here, just a touch, if you want to elaborate on that, that'd be great.
Yeah, absolutely. I started CIG in 2017. I was working in commercial insurance at the time, and I went to the emergency room, and I was denied the appropriate access to care because I needed opioids. I was having an acute pancreatitis, and instead they sent me home. I spent the next 9 months being doctor bounced, accused of drug seeking everywhere I went, and I was getting sicker and sicker and sicker in the process. And even some doctors had acknowledged to my face, like, I know you're really sick, but I'm not losing my license over you, sorry. And eventually I did find my way to a doctor, and he did reperformed, and he had found out I'd suffered from something called superior mesenteric artery syndrome. And what that is basically I had vomited so much, and I had lost so much weight so fast that my superior main vein had actually collapsed, and it had landed on top of my digestive tract and crushed my stomach and 2 parts of my organs. So I was not able to eat. I was not able to really survive, and I was slowly wasting away and dying with inability to eat. And I finally found a doctor willing to help me. And in the process, I started the company because I was making phone calls saying, like, to state representatives, to everywhere I could think of, the pancreatitis. I'm like, please help me. What's going on? Like, what do you mean I can't have access to opioids? I'm sick. I have insurance. Can't you help me? And I came to this like grim realization. no, nobody can help me. Oh my God. And if I don't do something, I'm going to die. And I ended up like just really starting with a petition that turned into a Facebook group, that turned into a Twitter group, that turned into an organization. And it just kind of flowed up from there and it just went day by day by day. And then suddenly I was running an organization and we've got partners and we've got a fully developed thing going on. And it's all really been out of that accident that I ended up building the corporation and meeting with a number of our partners and building a full board and being where we are today.
Wow. So sorry to hear about your experience. That's terrible, but you know, grateful that you can advocate and raise awareness for other patients that are dealing with similar issues. You mentioned in your talk as well about, you know, kind of the increasing rate of suicides as well as the increasing use of patients going to the street to be able to manage their issues versus being able to get the medications that they previously were given. Can you elaborate a little bit more about that?
Yeah, you know, a lot of patients unfortunately have been forced off of their medications against their will. And, you know, at that point, you really are left with three choices. You suffer, you self-medicate, or you kill yourself. And unfortunately, a lot of people, there's only so long they can suffer. And I myself have been touched by pain by suicide last year. My father actually took his own life 5 days after Father's Day. Because his pain was not being treated appropriately with cancer. And he took his life over this. So there's been a lot of suicides that, you know, I was even shocked to be personally touched by, considering, you know, I do this for a living. I never would have imagined my own family would be one of those people. And we've seen a lot of people it's been a really, really huge discussion online. And we've seen so many people talking about their ability to do their jobs and raise their kids and have lives, and how it was stripped away from them when medication was taken away. They weren't left with anything else. There's a big fallacy that like, oh, there's other treatments, not effective ones. I mean, if we want to talk about effective treatments or treatments, well, there's lots of things they could do, but it doesn't mean they're effective. And a lot of these people aren't left with effective treatments, and it collapses their life.
Wow, that's pretty deep. Sorry to hear about your father. That's unfortunate. I also had a situation where I had to, you know, accept a family member's diploma at my high school graduation because of suicide. But so I certainly feel for you there and accept my deepest condolences, please. But you know, the other thing is I would open it up to the floor if there's anybody else that wants to raise their hand or post a question in the chat for Lauren. Any burning questions out there from Jane or Leah or Bill or looks like Stephen? Anybody want to unmute and ask a question of Lauren?
Yeah, hi Lauren. Thanks so much for your talk. I actually missed a bit of it. And as a nurse, I noticed that it seemed like overnight, everything had switched so much. I was taught as a nurse there are 6 vital signs for everybody, and pain was included in that. And I was taught, you know, you don't judge what somebody's pain is. Whatever they tell you their pain level scale is, you can't see just because they might be smiling at that time that you say, well, they're really not in pain. We justify exactly what that person says as being their level of pain. And then it just seemed like that just like literally got pulled out, and all of a sudden patients, you know, they didn't have a place to go. And do you have any idea what the underlying motivation was that behind that, or did you cover that and I just missed that?
Well, what we found in our research that, you know, in all of these bills and things that have passed and what we're seeing taking place is that really the bottom line of this is a healthcare expenditures. And I don't know the exact, you know, calculations because I'm not privy to that type of information. But everything we've read is that pain costs society $650 billion a year, and that it has been calculated probably by the federal government and not a number that we're allowed to see, that it would be a cost advantage that if people self-medicated or self-managed, where they would no longer seek medical care for pharmacological treatment, pain treatment, that they would learn to self-manage their pain through cognitive behavioral health, coping skills, you know, all the things that most people who've been put on opioids already tried. physical therapy, acupuncture, things like that. And they're trying to actually basically put everybody back through these modalities, and they're being tested on the back end and being studied to see how effective are they. And unfortunately, we've seen a lot of stuff where people seem to cherry pick the studies. So we've been seeing a lot of conflicting information out of there.
Did you cover how many people have, taken their life since not being able to get adequate care for their pain?
That's actually one of the areas that we are advocating for it to be better tracked. That is not something that the government is tracking. I know that some universities are doing some studies on it, but as on a big grand scheme of thing, it is not being tracked at any level, and neither is medical errors, actually, because at the grand scheme of things, I'm a big medical error from this policy change, but I am not logged anywhere. How many other people in society have been injured by this, and there is no tracking of all the increased medical errors that have happened? So those are areas that really they're lacking the impact studies. They're lacking quantifying the damages that this has done. So that's what we have been promoting, and that we will be continuing to promote for our work, that it does need to start being looked at, because you can't just keep proceeding. And right now we see this very disturbing trend of lower prescribing means success. And it's like, well, but wait, we have higher suicides, we have higher disability, we have higher everything, but lower opioids is good. So there's just been a really lack of accountability on what's taking place.
I totally agree. Thank you so much for everything you're doing.
Thank you.
Leah, I think you wanted to make a comment. Can you unmute? There you go.
I think you can hear me now. Hi, my name is Leah Lonebear. I'm actually the director at CIAAG. I work with Lauren. And I too lost my father because of this. And I too was severely injured because of this. So her and I have lots in common. I did some preliminary research into the suicides. It's very difficult because, as Lauren pointed out, the information is severely lacking. But just a rough estimate that I came up with is that in the past 5 years, which is basically since the institution of the 2016 guidelines from CDC, there's been approximately 75,200 attempts a year. And they say that 1 in 5 is related in some way to opioids. So that would make it about 6,800 a year.
Oh, thank you, Leah.
In terms of suicides.
Yeah, when I traveled actually to the United Nations in 2018, I went to the Office of Drugs and Crime to testify with the NGO committees, and they had actually did a presentation there, and they actually think that it could be as high as 1/3 of all suicides are for untreated pain, and they think that even that might be even lowballing it. So it could be anywhere between 1/3 and 50% of all suicides are untreated pain. But again, it's just not been something that's tracked properly.
I think that the numbers I came up with were extremely conservative.
Yeah. Thank you.
All right, I'll give it back to you.
Thanks for bringing that information to us, Leah. That's so unfortunate, but so startling too, to some extent. I mean, it's a significant amount of people that are, could directly be cared for in a better way. I guess, Lauren, that would be as a healer myself, as a surgeon, obviously is some push within my own practice to try to move away from opioids if I can, to avoid that addiction component, right? Because there is that quota or data that shows that, if you start on a prescription, there's a certain, I think it's like somewhere between 15 to 20% of folks that will end up still on that same prescription a year later, even for temporary pain. So what would you say to the medical community, as far as the healers, as far as patients, et cetera, to kind of, what is your view on how these stronger medications should be used, and what's the best way for us to move forward to make sure we're taking care of folks and not, you know, say for instance, pushing them to the streets or pushing them to these significant, you know,
Yeah.
complications like suicide or et cetera.
Yeah, I think, a big part of the problem is that there's been too much bad data presented to physicians. Everybody is getting a lot of propaganda. Even what you had just quoted to be 15%, the actual numbers are between 1% and 3%. Well, actually, I would actually say your quote, I apologize, the addiction, the amount of people who are given a medication who may become addicted is 1% to 3%. And in your example, I used where you said 1 year later. Well, what they're failing to report within that data is, are they still sick 1 year later? Did they have a permanent injury? They're not on it 1 year later because they're like, oh, it's because they actually are, and the surgery didn't fix it entirely. So like, and that's like, that's a disingenuous study, because yes, the result was true, but everybody knows that interjected a thought that means there's a problem here. That doesn't necessarily mean there's a problem, because those 15 to 20% may be complex patients and just are on it not because they were introduced as surgery. Maybe there was a complex, something that went wrong. Maybe there was an additional reason to keep them on it. It's not that they're on it because they're milking the doctor, because if you really think about it, that would say that 15 to 20% of doctors are just throwing pills at people whenever they ask. And you as a doctor, that's nonsense, especially in today's environment. That does not happen by the majority of doctors. So really, I think the best thing that any doctor can do right now is to take what they're reading with a grain of salt and double check. People don't have time to check references and all this stuff. And as a physician, the best thing you can do for your patient is to just be their physician, despite the guidelines. And of course, that is not something everybody can do. It's like, I'm going to throw these guidelines out. But I've been to doctors when I went through my experience, were so regimented on that CDC guideline, they were going to let me drop dead for it. And they literally looked me in the eyes and she's like, you're gray, you look like you're almost dead, but I ain't losing my license. Sorry. It's like, she had an ethical decision at that point to make and say, this is a guideline. She is sick. She is ill. I can start her at 5 milligrams, titrate her up carefully, watch her do their job. That's what a doctor eventually did with me. They brought me in at 5 milligrams a couple times a day, and they did their workup. They did what needed to be done, but they made sure I wasn't dying in the process. And it actually, because of the new rules and stuff, it actually took almost 3 years for me to be titrated to the proper level of relief. And even that is unnecessarily long to make someone look under medicated. So for 3 years, I barely got out of bed because I couldn't be titrated up out of fear to titrate me up too quickly and then be flagged and then lose my medicine. And it was a doctor being cautious as well. And I had to just deal with it because it was the only way I could get any sort of treatment. But it did, and he was a wonderful doctor. I am not saying anything, but because he was in a position, he had to make that hard choice. But he did do the right thing. And me as the patient, I could deal with it knowing where he was, that no, he's not going to rapid fire me up, and I have to be patient as well as a patient, that I'm not going to be like, I need 80 milligrams and you just need to give it to me. It's not going to happen, even though that's another debate for another day about whether people should get what they think they need. And, it's very complex. But I think, as a doctor's standpoint, is to take the guidelines for what they are, guidelines. And you can't, and a lot of there is a propaganda and things like that. So, to do that, to take every patient for what their unique situation is, and to be careful to not mistake a patient's, being upset and frazzled for a mental health problem, because a lot of people in our position have been so heavily abused, they are on edge that you're about to abuse them and that you're about to take their medicine. And, that can be quickly converted to, well, you have a mental health problem. And now you're spiraling them into a PTSD. And this is how medical PTSD starts, because they get gaslit and then they get upset and then they get gaslit more. So I think just really that maintaining that physician core relationship with the patient and not letting the guidelines dictate the care. You dictate the care.
Yeah, that's a great point. I mean, I think the especially the point about the research and literature not necessarily being the most founded, right? And a lot of that is funded by the opioid industry. I mean, obviously, even just look at 2020 as an example. I mean, look at how many journal articles were either completely false or retracted based on the COVID crisis and et cetera. Obviously, you know, a lot of these studies that are out there are funded by pharmaceutical companies and et cetera. And, you know, it's just like the insurance industry. They're gonna push any study that doesn't fit their narrative to the bottom and promote the ones that are most beneficial for their party line, right? So
exactly. And that's what we're seeing happen. I mean, all the opioid studies that ever exist seem to no longer exist. You can't find them. They're just gone. And it's like there's thousands of studies that have been taking place on opioids. You can't tell us that there's never been a study of opioids, especially the research we've done shows that they do have these studies. And I'd love to know where they buried them off in a deep dark corner somewhere, and they put all the multimodal treatment up on top and said, this is the best of the best, and this is evidence-based, even though it's not tested yet, but we'll call it evidence-based and put it in the hospital, and then we'll test it and see what happens. And it's become like this free-for-all of where like personal autonomy and rights are just being completely wiped off the table, and it's caused so much existential harm to the doctor-patient relationship, to trust within the industry. And you know, what we're working on is trying to bring that back to where it should be. We know we can't back this out to where medicine was 20 years ago and there was more freedom. We're not going to get that back, but can we at least bring it back to a level of sanity where, you know, the doctor has some control of his patient, and it's not a computer that's going to spit out an algorithm that was ran by a corporate entity that happens to sell that product, who happens to have stock in that. And it's like, wait a minute, so this is not good for the patient, this is good for your pocket.
yeah, correct. And with that, we're just over the top of the hour, so I'm going to share my screen one more time and just touch base back to the Freedom Hub, Freedom Health, website here, just to make sure that everybody can find these webinars. Again, you can see here at the top of the main page there, you'll see the webinars posted for each week. Again, the 4 p.m. Eastern and the 7 p.m. Eastern, 7 p.m. Eastern, focusing mainly on healthcare and health freedom, the free market cash patient, as Lauren has posted in here with the Chronic Illness and Awareness and Advocacy Group. And we thank her so much, and as well as everybody else who's joined us this evening for all the information that was shared. And ultimately, obviously, again, as you scroll down, you can get to the links for all of the registration for each week, but also for the different avenues to which you can go back and find these recordings and go back through the different podcast webinars that we have. Thank you so much, everybody, for joining. You all have a great night.
Great. Thank you for having me.